Welcome to the Abusive Head Trauma Prevention Training for Child Care Providers. This training is directed toward anyone who works or volunteers within a licensed child care facility. The content of this presentation serves as a source of information for child care providers to utilize within their work and interactions with children as well as their parents. During the next few hours, we are going to talk about a very serious threat to babies and small children, the circumstances that can lead to tragedy, and ways to prevent it from happening. As a child care provider, you play an extremely important role in this effort. If you work with babies and young children, this information will be very applicable to your daily work. Equally important is your unique ability to share this information with parents in order to protect children and ensure their safety and well-being. Everyone in the community needs to be aware of the need to support parents and safeguard the health and well-being of children. As a child care provider, you can be one of the forerunners. The learning objectives for this presentation include the following: to build awareness of abusive head trauma, its adverse consequences, and how it is preventable; to gain an understanding of the period of purple crying; to develop the knowledge and skill to handle the challenges and transitions of increased infant crying, including soothing strategies; to create a crying plan in order to avoid becoming overstressed or overwhelmed by infant crying; and to be able to support and educate parents, caregivers, and other staff about abusive head trauma and coping with normative crying. As you go through this training, remember to listen with dual perspectives, both as a caregiver of young children and as a source of critical support and knowledge for parents and the community. All babies cry. Crying is an essential form of infant communication with caregivers in order to get their basic needs met. From the moment they are born, babies cry to communicate hunger, discomfort, over or understimulation, fatigue, or dysregulation. However, some infants cry more often, longer, and more intensely than others. They can cry for no apparent reason, and caregivers may be unable to soothe them. Inconsolable crying can be very upsetting and frustrating for caregivers. So what is the relationship between infant crying and shaken baby syndrome, a form of abusive head trauma? The number one trigger for shaken baby syndrome is frustration with infant crying. When a caregiver becomes overly frustrated with an infant crying, adverse consequences can stem from that frustration, particularly shaken baby syndrome. Shaken baby syndrome is one form of abusive head trauma. It also includes injury not only to the brain, but also the skull and spinal cord, which can result from shaking, but also from inflicting trauma on the head by other means, such as throwing, intentionally dropping, striking, or other forms of impact. Shaken baby syndrome occurs in babies and young children who are vulnerable because they are wholly dependent upon caregivers, because they are small in size and are not capable of defending themselves. The term shaken baby syndrome is defined by the collection of signs and symptoms specifically resulting from violently shaking a child or shaking a child and causing the child's head to hit an object such as a wall, furniture, or the floor. Shaken baby syndrome is inflicted by an adult on purpose. There are some typical movements and activities that do not cause abusive head trauma, such as tossing a baby in the air, bouncing a baby, jogging or running with the baby, short accidental falls, like falls from a couch, sudden stops or bumps, Abusive head trauma is an act of abuse and easily recognizable as abuse. A typical observer would never confuse it with play. Throughout the remainder of this training, we will use the medical term abusive head trauma, or AHT, rather than the term shaken baby syndrome. More important information. The brain comprises 25%, or 1/4 of an infant's total body weight. It is very heavy in comparison to the rest of the body. In contrast, an adult's brain is approximately 10%, or 1/10 of the total body weight, much lighter to carry around in comparison. An infant's skull is roomier than an adult. Why do you think that might be the case? An infant's skull is designed to have more room for the brain to grow. So what might be the effects of that additional space between the brain and skull when a baby or small child is violently shaken? When an infant is shaken, the brain moves further back and forth and gains speed as it hits the surface of the skull. Additionally, blood vessels in infants' brains are delicate and not securely anchored, so the back and forth movement stretches, tears, and breaks the blood vessels, causing blood on the brain. An infant's neck muscles are so weak that it puts infants at high risk of injury from shaking or trauma to the head. Their neck muscles are not strong enough to stop the movement when the head is shaken. Like a floppy rag doll, it's a similar effect. Bleeding of the brain is injurious. Equally damaging is the swelling of the brain that occurs from the impact of the brain against the skull. The pressure from this swelling stops blood circulation to parts of the brain. This lack of circulation can cause those parts of the brain to die, resulting in permanent damage. So what actually happens when the adult violently shakes a baby or small child? As mentioned previously, because of their large head and weak neck muscles, they do not have the strength to control the movement. The strength of an adult shaking a baby causes an infant's head to move in a figure-8 pattern. This causes different parts of the brain to move at different speeds and in different directions. As mentioned previously, this type of motion can cause swelling in the brain, as well as tearing and bleeding of the blood vessels in the brain and eyes. As the back of the brain hits the back of the skull, damage can occur to the optical lobe, which controls vision. As the front of the head hits the front of the skull, damage can occur to the frontal lobe, which controls memory and emotions. As the left and right sides of the brain hit the corresponding sides of the skull, speech, hearing, and the movement of arms and legs can be affected. Abusive head trauma occurs among babies and children from birth up until 5 years of age. The majority of cases are among infants less than 6 months of age. However, severe shaking can seriously injure children as old as 4 or 5. Abusive head trauma can happen to any child, regardless of race, socioeconomic status, or family structure. However, young parents, parents with little support, those experiencing stress, those who are not able to meet their basic needs for food and shelter, those experiencing other forms of violence or at reduced capacity due to substance use or mental illness, and homes where unrelated adults are residing have increased risk. There are more male abusive head trauma victims than females. A perpetrator of abusive head trauma is almost always a person who has been entrusted with an infant's care. Parents, parent significant other, or child care provider. 60 to 70% of perpetrators are male, usually the child's father or the mother's boyfriend. Others include mothers, grandparents, step-parents, other relatives, or child care providers. Anyone who may become frustrated is capable of shaking a baby. It can happen to any child in any family. It is therefore very important to help caregivers become aware of the risk for themselves and for others, to be aware of the signs that shaking has or may occur, and to scrutinize those with whom you leave your vulnerable children. The United States averages approximately 1,300 cases of abusive head trauma each year. It is difficult to determine an exact number of cases due to differences in reporting requirements for each state, and the fact that many signs and symptoms of abusive head trauma mirror symptoms of other common childhood illnesses, resulting in misdiagnosis. Of the cases of abusive head trauma diagnosed each year, approximately 1 out of 4, or 25%, result in death. And for the victims who do survive, most will continue to have lifelong challenges resulting from trauma and damage to the brain. 60 to 80% of non-fatal cases show either short or long-term disability. Clearly, abusive head trauma is a huge threat to infants and children who experience shaking. The consequences of abusive head trauma vary and are different for each case. Early or less severe signs of abusive head trauma can be only slightly more pronounced forms of typical infant behavior or similar to symptoms of other types of illness. Such signs and symptoms can include irritability, sometimes extreme irritability or accompanied by high-pitched crying, lethargy or sleepiness, feeding difficulties, including trouble sucking, swallowing, or decreased appetite, vomiting, low levels of consciousness. When only the less severe signs of abusive head trauma are present, abusive head trauma can be difficult to detect, and there is a significant chance of misdiagnosis. Why is this the case? Several of these signs are also symptoms of other childhood illnesses. Caregivers either do not want their physician to know the true origin or symptoms, or may not know themselves, so doctors do not necessarily have a true picture or complete facts of what provoked the symptoms. Why is misdiagnosis so problematic? Any treatment is not addressing the true origin of the problem. The child is at high risk for future episodes of shaking. Let's talk a moment about sentinel injuries. Sentinel injuries are minor abusive injuries that often present themselves before a more serious physical injury. They can come in many different forms, such as bruising, burns, broken bones, injuries to the inside of the baby's mouth caused by ramming a bottle into the mouth. These types of injuries are not likely to happen without a cause, because they primarily occur in early infancy to babies that are not mobile enough to be injured by obstacles around them, or in places that an infant cannot reach, or that are not exposed for injury. Examples include a bruise on an arm or leg of an infant who is not mobile, a bruise on an infant's ear, or cut or bleeding in the mouth. Research shows that 27.5%, more than 1/4, of abused infants had an earlier sentinel injury. Reportedly, doctors were aware of the sentinel injury in less than half of the cases. Just remember, babies who are not cruising should not be bruising. If you are a caregiver or parent who notices bruising, red marks, or mouth injury in a very young child, consider consulting a physician. For severe cases of abusive head trauma, symptoms can include inability to make sounds such as cooing, babbling, or words, or movement or lack of social engagement, such as lack of smiling, tracking, or focusing on objects. Difficulty breathing. This may be evidenced by skin color. Pale, blush skin indicates lack of oxygen, or unusual breathing patterns, such as continuous deep breathing, or a pattern of short and shallow breathing. Seizures. Damage to the blood vessels of the eyes, which can cause bleeding. Bleeding or drainage of clear fluids, spinal fluid, from the ear. Inability to coordinate sucking and swallowing. Loss of consciousness or death. Physical signs that can, but do not always, accompany abusive head trauma are wounds or bruises on the skin, fractured ribs, arms, legs, or other bones. If you see any potential signs or symptoms of abusive head trauma among the children that you work with, you need to report them or have them checked by a physician. It is also important to share information with parents, the signs and symptoms to watch, so that they are aware and can identify them if their child has been with another caregiver. As mentioned earlier, among victims of abusive head trauma that survive, 60 to 80% of hospitalized cases have shown long-term or lifelong effects. These effects may include learning disabilities, visual disabilities or blindness, speech disabilities, ongoing seizures, cognitive impairment, physical disabilities, hearing impairments, cerebral palsy, and behavioral disorders. Not only does abusive head trauma affect the victim, but it also carries a large impact on caregivers and society. Many of the long-term effects of abusive head trauma require special services, additional medical treatment, and round-the-clock caregiving support, not to mention the extreme financial burden and time commitment associated with these services. Estimated average lifetime cost for a surviving victim is approximately $2.6 million. Abusive head trauma creates a high risk for potentially devastating consequences. Therefore, efforts to prevent abusive head trauma are extremely important. Prevention efforts focus on providing education, promoting awareness, and offering support. The next section of this training will center on normative crying, the developmental period when infant crying increases, why it's important for caregivers to understand crying and be prepared for it. In your dual role as caregiver and support to parents, information on normative crying is useful and should be shared with parents. An early study on infant crying performed by pediatrician Dr. T. Barry Breselton in 1962 first demonstrated increased crying in the early months of infancy is a normal stage of infant development. The trajectory of increased crying is demonstrated in the crying curve found on this table. As you can see, the amount of time infants spend crying during the course of each day begins to increase slowly but steadily at approximately 2 weeks of age. The amount of time an infant spends crying during a 24-hour period generally peaks around the 2nd month. Around the beginning of the 3rd month, the amount of daily crying begins slowly but steadily to decrease over time, and generally tapers off around 4 to 5 months. Amount of crying. The total amount of crying time per day varies from infant to infant. Low criers may only increase to 20 to 30 minutes per day, while high criers can wail for upwards of 5 to 6 hours each day. Regardless of how much a baby cries, all babies increase their crying during this period of their development. Premature babies experience this same crying curve at approximately 2 weeks of consecutive age. Parents really need this developmental information, especially new parents. However, any parent, caregiver, or child care provider can find themselves in new territory where a child's crying pattern feels very different from previous children, or a child is especially difficult to soothe. Here are some examples of questions to start a conversation with a parent about crying. How often and how long does your baby cry? Have you noticed specific times when your baby cries more? How are you coping with the crying? The crying curve is not cultural specific. In the Kung San study, an observational study of the Kung San tribe supports that this increased period of crying is seen in all infants, not just those of Western culture. Kung San is a hunter-gatherer tribe in Botswana. Kung San tribes does everything known to soothe infants during the course of their normal day-to-day caregiving, such as constant contact with mother, baby wearing or constant carrying using a sling, not only in response to crying, continual feeding every 15 minutes for the first 2 to 3 years of life, upright posture through use of a sling, quick universal response time, on average responds within 10 seconds, 92% of the time. Yet their infant's crying follows the same crying curve pattern of other infant studies. This provides strong indication that this pattern of early crying is not due to differences in caregiving, but is a normal period of development. It is also important to note one difference found. The Kung San infants' length of crying periods were shorter. This may show that increased efforts to comfort an infant may reduce the length of crying. We know that there is a normal period of development in an infant's life where crying increases. We also know caregivers' frustration increases during this period of development. So what is the importance of this in terms of abusive head trauma occurrences? The above graph shows data from a study that analyzes 273 hospitalized cases of abusive head trauma from 1996 to 2000 in the state of California. What the data shows is that the number of cases of abusive head trauma increases with the amount of crying as demonstrated on the crying curve. The highest incidence of abusive head trauma corresponds with the peak of the crying curve, where the highest amount of the baby's day is spent inconsolably crying. Since the period of heavy crying occurs within the first 6 months of life, most abusive head trauma victims are less than 6 months of age. The research and evidence is there. Infants have a normal period of increased crying, and occurrences of abusive head trauma align with this period of development. So how do we help educate and make caregivers aware of what to expect during this time? What knowledge and resources can we instill to help ease frustration and prevent abusive head trauma? The period of purple crying was developed by Dr. Ronald G. Barr and is a phrase used to describe the time in a baby's life when they cry more than any other time. The PURPLE acronym is an easy way for parents and caregivers to learn and remember the characteristics of the type of crying that occur during the period of purple crying. P stands for peak of crying. Crying starts to increase around 2 weeks, peaks in the 2nd month, and gradually decreases in the 3rd to 5th month. U stands for unexpected. The crying can be unexpected and difficult to plan for because it can come and go at any point without any rhyme or reason. R stands for resists soothing. No matter how many different things a parent or caregiver tries in order to soothe the baby, It may not work for some or even all of the time. P stands for pain-like face. A crying baby may look like it's in pain, even if it's not. Although it is okay for parents to get their baby checked by a physician if they feel concerned. L stands for long-lasting. Babies can cry up to 5 hours or more each day. E stands for evening. Babies are often likely to cry more in the late afternoon and evening during this period. Having a crying baby does not mean someone is a bad parent or caregiver. As long as the baby has been fed, cleaned, provided with an appropriate environment, and opportunities for sleep and snuggle. The word period in period of purple crying means that the time frame where prolonged crying occurs has a beginning and an end. It's important to understand crying can occur outside of these parameters as well. Parents should always be supported in seeking medical help to learn whether their baby's crying pattern is normal or a sign of illness. Purple crying versus colic. Researchers use Wiesel's criteria to define colic, such as a healthy infant that cries at least 3 hours per day, 3 days per week, for at least 3 weeks. Crying periods start between 3 and 21 days and subside by 3 to 4 months. Crying occurs in the evening, and the crying baby has flexed legs with a pained look on their face. Do these characteristics sound familiar? What was referred to as colic is now thought to be a normal developmental stage with variances in intensity in individual babies. The term colic in the medical field has no accepted diagnostic criteria. It's often used to describe an overly fussy baby that has no medical reason for the increased crying. However, colic is understood by most people to be an illness that some babies have and others do not, which can imply that there is something wrong with a baby, when in fact, all babies go through a normal crying curve. Some babies just happen to cry more than others within that curve. It's important to remember, even though it is normal for babies to cry a lot during the period of purple crying, some babies do cry even more than the highest range of normal or actually in pain. So it's important to support parents and caregivers who feel that their baby needs help or that they need help with their baby so that they can get the assistance they need, whether that might be medical diagnosis or support for parenting. Now that you know the characteristics and general time frame of the period of purple crying, can you think of strategies that you've seen, heard about, or used yourself that could help a new parent or caregiver cope during the period of purple crying? 7 principles of soothing. Change baby's position. Changing a baby's position can provide different points of contact between you and the baby. Change the baby's view. Provide eye-to-eye contact between you and the baby, and allow the baby to stretch different limbs and body parts. Examples include picking the baby up, laying the baby down, holding the baby over the shoulder, carefully balancing your baby over the arm or leg, and holding the baby facing up. Movement. Movement is very soothing for babies. Caregivers can use their own movement to soothe babies or use mechanical means to provide the movement. Examples include walking with the baby, using a swaying motion, up and down jiggling motion, pushing the baby in a stroller, riding in the car, putting the baby on top of a cycling washer or dryer with careful supervision, using a baby swing. Repetition and rhythm. Repetition and rhythm often go hand in hand with movement and with one another. Repeating soothing things is calming, particularly when repeating in a pattern. Examples include walking in a pattern or making the same movement over and over, like rocking a baby or pushing a baby back and forth in a stroller. Singing songs, telling a nursery rhyme or story, patting a baby's back or placing the baby on your chest so that they can hear your heartbeat. White noise. White noise is sounds that often without a rhythm, such as random background noise that does not have a melody. Examples include the sound of a vacuum, shower, hum of an engine or fan, or even a white noise machine. Whatever you choose to make the white noise, make sure the infant is safe and secure. Smells, sights, and sounds. We often forget that baby senses are very sensitive. They can identify and be soothed by familiar smells, sounds, and sights. Examples include wrapping the baby or covering the caregiver's shoulder with a familiar blanket that isn't or hasn't been recently washed. Keeping a cloth item with a parent or familiar caregiver near the baby in a safe manner, of course. Human faces are recognized and soothing to babies, as is the human voice, particularly that of a parent or familiar caregiver. Closeness to the caregiver. Being held and snuggled is extremely important and soothing to babies. Examples include skin-to-skin contact, cheek to cheek, carrying, sitting on a lap. Sucking. Sucking motions begin in the womb and can be very relaxing for babies. Sucking that is unrelated to food intake can be just as soothing when a baby is not hungry. Examples include sucking on a pacifier, sucking a thumb or finger, though it takes many babies some time to coordinate their fingers, or even a caregiver's clean finger. It is a myth that you can spoil a baby. Spoiling a baby is not possible. In fact, a caregiver's responding to an infant's signs of fussiness quickly and consistently actually lessen inconsolable crying bouts, as well as strengthening attachments between the caregiver and infant. It is not an easy feat to take care of yourself while dealing with an inconsolable infant. But when you take the time to manage your frustration, you not only benefit from the reduction of stress, but also limit the possibility of harming or shaking an infant. Here are 3 strategies for dealing with frustration that you can share with parents. Take time to calm yourself. This is the first and most important step. It is more important for parents or caregivers to stay calm than to stop the crying. Parents and caregivers should think of some calming strategies before they are dealing with a crying baby. Examples might include walking, taking deep breaths, listening to music, watching a mindless TV program or movie. Remember, if the parent or caregiver is able to relax, it helps the baby also. Infants feel caregivers' emotions and respond accordingly, which does not mean that a crying baby is the fault of the caregiver. Mindfulness. Try to stay focused on the task at hand. Even though the baby is crying, parents or caregivers should try not to allow the baby's crying to stress them to the point that they are so stressed and distracted and cannot concentrate or complete their task. Take a break. It is okay for parents or caregivers to take a responsible break. Lay the baby in a safe place, using recommended safe sleep guidelines. Parents or caregivers should take time to calm themselves. Once calm, they should try soothing techniques again. Check on the baby often. Remember, feelings of frustration are normal. It is okay for parents and caregivers to ask for help. These are strategies that you can share with parents when they express frustration due to their baby's crying. Human beings are biologically programmed to be very sensitive to infant crying, so it's natural to become frustrated when a baby is crying inconsolably and a caregiver is unable to do anything about it. However, it's essential that parents and caregivers have a plan so that the frustration does not escalate out of control. It's hard to imagine someone ever being frustrated enough to harm an infant, but it happens 1,300 times each year. Perpetrators often say they could not have imagined harming an infant, but that the frustration just took over. Every caregiver of an infant, whether a parent, child care provider, or relative, is responsible for having a plan of action in place in case that were ever to happen, if they were ever to get to their boiling point. The first step is for parents and caregivers to identify a couple of individuals who they can turn to for help. Alert those persons so that they are aware and prepared to help if needed. Have their contact information available, easily available, so when a parent or caregiver is at their wit's end, they do not have to go looking for that information. Practice asking for help. Parents do not have to wait until they are at the end of their rope to ask for help. They should practice seeking help at times when they are less frustrated. While information about abusive head trauma may be important to you personally, it is also important to educate and share with others if abusive head trauma is going to be eliminated. Each of you can be an important spokesperson and educator for yourself, other child care providers, for parents, and for the community. Highlights of this presentation are available in the brochure, Babies Cry, Be Prepared, which contains general information on normal infant crying, strategies to stay calm, and how to prepare for stress associated with infant crying. Here are some key takeaways. The period of purple crying is developmentally normal. When babies can't be soothed, frustration is normal. Develop a variety of soothing techniques. Support your own well-being by learning how to self-calm or take a short break and walk away. Create a plan for times when crying becomes overwhelming. For additional resources, go to purplecrying.info. Here are some additional resources that can assist you in helping to educate other caregivers, parents, and the community about abusive head trauma. This training was developed by the Wisconsin Child Abuse and Neglect Prevention Board and the Wisconsin Department of Children and Families. A special thank you to the National Center on Shaken Baby Syndrome for providing professional knowledge, expertise, and collaboration through the development of this training. Thank you for participating in this training brought to you by Networx Training Academy.